Okay, that's good. A couple of comments. Half of the health systems we speak to have an issue with the statement we make up there about no history of drug abuse. They'll say, I'm sorry, Eric, but if I have a trauma patient and if they're drug abuse, we have to find an appropriate pain management regimen for that patient. So that's a matter of an individual health system's decision as to how they're going to manage that. The device that you see here is different than the one in the video. It's backlit. We made many changes to this device over the years. We've been using it on patients. One of the things patients said is, I don't like in a dark room, I can't find things. So we put backlight on this, and it's controllable as to the light intensity. We went from a touch panel to actual buttons where you get a physical pushback on the pain score. Patients really like that. We also added a feature that nurses wanted. It has an audible prompt for reassessment of pain. So if you're doing a Q4 hour, we would do a 2-hour reassess. If you're doing a Q2 hour, we do a 1-hour reassess. The device will automatically say to the patient, please enter your pain level now. And it will keep repeating that, and the light panel will kind of brighten and darken for 20 minutes. If after 20 minutes they don't respond, then you won't get a reassessment value. Everything that we talk about is stored in a database. It's a Microsoft SQL database, stored for perpetuity, and then I'm going to show you a report that I generated, a mock report, and I have some copies of it in those folders there if anyone wants to take one. So any piece of data that we have is stored in the database. So what? Well, you may want to look at data that's not going to be readily available to mine in the EMR. For example, we could look at all the patients on a unit. There's a unit designator you can put in. So we could say, oh, let's look at all ortho patients on this unit on a mod. Does anybody seem to be staying at a 10, 9, 8, not sort of seeing an improvement in pain over time? Well, that might be something you want to red flag, because that patient might be responding differently to that particular medication in that particular period of time. Pharmacy can monitor every mod in real time. They can see every mod, the last pain score, and how many pills are left. So a lot of features were added with pharmacy input, patient input, and nursing input. So this is a much different device than what you saw, but nonetheless. I thought I'd start at the end because we're all clinical folks here. What do our clinicians say about the mod? Well, they say on every ward that we've put it, it has increased awareness of how patients' pain should be managed. It raises the dialogue about pain management as a whole, which is a good thing. Most patients overwhelmingly like the mod. They have some comfort in knowing their medication is there. Because, you know, on most HCAHPS scores, how do patients rate the nurse? Very highly. They like the nurse, and they feel a bond with the nurse. So they're not going to say the nurse didn't do a good job, but they may say separately, but my pain wasn't well managed. So they differentiate those two things. We found a lot of times, once we put them on the floor, there's a lot of interest in the staff on just delving more into pain management, understanding the medications, understanding the different pain modalities, because most people are using multimodal pain management. They're not using one thing. They may use PCA, they may use a block plus orals. You know, they may use an injection. But it raises the dialogue and interest and discussion among clinical professionals about pain management in the facility, every single one we've been in. We talk about patient engagement in healthcare. This is pretty engaging for the patient. And the nice part about it is we've seen, and the comments coming from the nurses, particularly in the joint units, is we had a hard time with some patients. I'm one of them. I'm a knee replacement patient. You know, understanding the importance of taking your medications on a regular schedule. Because, oh, you know, that won't hurt me. Well, it gets the patient thinking about the idea of getting ahead of their pain. And they know that if they need the medication, it's there. Now, we still tell them, you know, don't wait until your pain level is here to take a medication. But to be successful with their physical therapy as outpatients, they've got to get used to the idea of pre-medication. So we find this really helps the nurses feel confident when they're sending that patient home that the patient's going to comply with the medication regimen to make their physical therapy successful. And if their physical therapy is successful, they won't be readmitted. So we don't have an infection. In labor and delivery, this is interesting. We just came from Tampa General, and they have 2 45-bed maternity units, which is huge. 960-bed regional hospital. And they're really strongly advocating a return to nursing. Nursing babies, withdrawing formulas. And what they found is they observed that these mod patients were had better pain management and were more compliant with trying to learn to nurse. And they told me we have people on the ward beginning at age 14. We need a lot of education and support. So that was sort of an unintended benefit, but it works out rather well. So the other thing that was kind of an interesting development for us was our first hospital is Flagler Hospital in St. Augustine. They have 45 mods. Several patients were discharged to a rehab facility called Bayview. And when they got there, they asked the nurse, do you have one of those mods here? And they said, well, no, unfortunately we don't. Well, subsequently, they bought mods. And now what's happened for those patients is there's a nice story of continuity of care. They used to using the mod after their operation, they got discharged to rehab, and they're using it in rehab, where they push them a little bit more for physical therapy, especially the 2 knees, the 2 hips. So we also got approached by Senior Healthcare, which is a very large skilled nursing facility management company. They have 39 facilities in rehab, and they manage another 40. They just deployed it in 3 of their facilities. When they went to visit Bayview, they said, this is a great idea. And they're going to be held to some liability in terms of the success of pain management. They're nothing like the Joint Commission is in a regular acute care hospital, but that will happen. So this is what our clinicians say about this. What I'm just going to talk about is how does it work, pharmacy-related questions, patient and nursing benefits, what happens versus manual delivery, and then I'll show you a little bit how the device works. So what is the mod? It's patient-centric, it's evidence-based, it's a tool to increase nursing efficiency, and it improves overall quality of care, and is wireless. So how does this work? It's programmed by the hospital network, so you log into your workstation, there's an icon for the mod, you click on it, you connect to the mod, the nurse does, and I'll show you that right here. Every patient gets an RFID wristband, which is only linked to that device. So only that patient can access that device. It won't work anywhere else. If you don't want to use an RFID wristband, and you have, like in labor delivery, a lot of different wristbands, we have a wrist wrap, which just wraps around a wristband. So you don't have to add another wristband if you've got wristband crazy already. The patient, as I said, the light goes green, the patient knows their medication is ready. They press the pain score, hold their wristband just over the front of the device, and it opens and gives them one pill. We only put 1 medication per well. We don't recommend more than. We've been asked about that. It was really designed for 1, and we think from just a accountability perspective, it makes sense to use it the way it was designed. We recapture all the data, and we want to make the point, of course, it doesn't replace nurses, but we know that nurses are faced with more higher acuity patients on the floor, patients requiring more bedside care. This is one of the things that frees time up to do that better. And I think most nurses like that idea. So this is just to give you a quick shot. You'll see it over there. This is what comes up. You press there's a little dancing man button on the front, and you put in a 3-digit number, and that allows you to talk to only that mod on your whole network. So that's how we communicate with just 1 mod. So you have to be close to it when you do the programming step. You have to be close to it when you load a new tray, and you have to be close to it when you discharge and reconcile any remaining medications. Other than that, you don't have to be close to the device. What happens, basically, we said, you enter your pain score, you hold your wristband over the front of the device opens, and you take your medication. You have 40 seconds to do that. Again, manual delivery, usually we see 4 hours, meds peak past the 4 hours. Delivery is very inconsistent. We said 11 minutes on average. We saw data between 8 when people could run to 17. Right now, we're doing another study at the University of Pittsburgh Medical Center right now, which is directly comparing mod care to usual care. It's a double-blind study recruiting patients to both types. We're giving ED to the patient on the front end of both usual care and mod care, so we're treating them all the same. We want to see really in that true study what's the difference. Okay? A lot of times, this is an important distinction I need to mention. The mod does not require a level of pain to give a medication. It doesn't support, for example, range orders or lower levels. What we find is, because the patients can truly put in their pain level, we feel that's what they're doing, but they will get a medication from a pain level of 1 to 10. There's no way to tell the mod, don't give them anything below 3. So that's a difference. We do a lot of 2-hour meds. We do a 5 milligram oxycodone Q2 hours. Patients seem to like that. Staff members like that because the patient seems to get a very level, stable blood level of medication that way. Whatever you put in your formulary can put in the mod, within reason. If you want to use Percocet, you can use Percocet. We have one facility in OB that's got 2 mods, one for ibuprofen and one for the opiate, because that's their regimen. And we don't want to mix that in the same tray, so we've got 2 mods. But we can program them to respond to the same wristband if we want to. Normally, they've got 1 mod by the bedside. We find, obviously, better pain management. Package trays of medication, there's 8 doses per tray, and I apologize, I don't bring any kind of controlled substances or anything in the hospital, so these are myths. But that's the tray, and that's how it would come from pharmacy, except that we have a barcode on it. And we see 2 kinds of barcoding techniques used. One is patient-specific barcodes, or just drug-specific barcodes. You got a dose, 40 milligram oxycodone barcode label. Some hospitals want it patient-specific, they use a patient-specific barcode. Totally dependent on their procedures. We recommend, and most people store it in their AccuDose or their Pyxis unit, ready to go. The pharmacy makes them up. We actually have a bulk loader. It's got 4 little tray holders on it, and you can load 4 trays at once. All of our programs have a second verification step. You can use it if you want to or not. But it requires, when the programming is done, that you can enter a nurse ID, any kind of a verification code before the program is finalized. And at the point where you discharge the patient, and again, I don't like that terminology. I like disconnect, DC the patient, but I'm working with the programming group. Basically, when you discharge the device from the patient, you do a pill count. And a second person can enter their verification, so you witness that. You asked about wastage. There's 3 things we see. Down the toilet, which of course the FDA does not recommend, because it's getting into the water supply. Second of all would be put it in the sharps container. And third, which I think makes most sense, is take the tray out, get a seal, reseal it, and put it back into the dispensing cabinet, because a lot of times the reconciliation is done at the ADC. So that means those pills go back to pharmacy. Those are the 3 methods. Down the toilet, sharps container, or return to pharmacy with a seal. The seals are inexpensive. You just reseal it and send it right back to pharmacy, and then it's verified. Some of the literature here, and I could give you anything you want. We've got a lot of studies, more on the way. This is interesting. Flagler Hospital, I said, is our oldest hospital, did a poster session for orthopedic nursing, and they compared basically the usual care to the mod. So the usual is blue and the mod is red. And basically how much interference they got from pain. And what you see is, in mood, activity, sleep, appetite, all the mod patients had far less interference from pain than the usual care patients. So they saw a real benefit. And this is what I'm not supposed to tell you who it is, but this is Flagler. They introduced the mod in Q1 of 2012, and they looked at the progress of their HCAP scores in the ortho unit. And as you can see, it was pretty obvious that they got a benefit. So they had 25 and they bought 20 more. We're also at Flagler talking about moving it into OB. They're in ortho now. Again, with 1.4 million joint procedures, we see this as a really nice match to what has to happen to those patients. As you said, going home, they've got to transition to orals. So again, we don't see this as a rapid result, because it takes a while for those HCAPs to rise based on the number of surveys. And as you know, only one question on the HCAPs relates to pain management. But we have seen this trend pretty consistently. How does it impact cost of care? You're using low-cost generics for the most part. How much do they cost? The pharmacist will tell you 8 cents to 12 cents. It may reduce pharmacy consults. Now, I'm not here to tell clinical pharmacists that they're not going to go to the floor. We all know you're going to. But amazingly, a lot of patients on the mod just progress without needing a lot of additional help. Now, we know that one med, if you see one hospital, you see one hospital. If you see one patient, you see one patient. So some patients might have to be switched from Percocet to oxycodone, or some other in the armamentarium of your formulary. Okay. Again, we see nurses liking the fact that they're able to do some of the things they need to do. They feel stressed with the number of patients per nurse. This is not a low-value activity, but it's an activity that takes time. And depending on where the patient's located in the design of the floor, I saw one hospital in Florida Hospital Network, that had round floors. So the nursing station in the middle, they could easily get to each room, but in many cases, that's not the design that we're living with. It's maybe a nursing station in the middle and, 48 rooms spread one way or the other. A lot of back and forth, right? This is an automated and technology solution, and some of them are kind of, being in this business for a long time, there's good technology and bad. The nice thing about this is these mods work very well. They're reliable, and they use technology in an intelligent way. They know they can record data and send it to a database over the network. So it replaces a manual process and does it pretty consistently. And what we've done some I have an ROI paper I can send you if you like, but basically we compared the cost. There was a really good study done by a friend of mine, Leslie Schechter at Thomas Jefferson University. She actually did a comprehensive study of what PCA costs, including complications. If you look at the cost of the mod is about 1/3 the cost of PCA for every day that you implement it. Just because of the difference between running an IV line and all the other things that are inherent in IV PCA. So it can be of significant savings. And PCA is reducing in frequency in hospitals. Some of the quotes we got from Teresa Lambert. By the way, if you want to talk to any of our reference hospitals, we have the CNO of one of them is willing to talk to anybody. We have some references that are willing to speak with you about their actual experiences. But our nursing staff has a better overall understanding of pain management since using the mod. Ortho patients, joint patients are very happy. In one of the hospitals, Hackettstown, they use a little goal program for their orthopedic patients. They set a goal sheet for them and accomplishments. So they like that the mod supports that to get the patients kind of motivated. Hey, you're gonna do this today in physical therapy. This is your objective. So it works right in with that goal-oriented patient release program. And a patient gave us a quote, having it at my bedside made all the difference in the world. So what's the evaluation process if you're interested? And again, I have no problem if you folks want to chat about it and say, hey, I'll get back to you in a week or two, talk about it internally, because the other reason for a trial, by the way, so what do? We find a willing unit. You've got to be willing. It's like, we're having, this is not the week to do a trial because we're rolling out the Epic. No, that would not be a good time. So find an appropriate unit that's willing to do this. We have a formal trial agreement that we have you sign. Why do we do that? We have to comply with the Sunshine Act, which is no free goods. So we do trials usually from 1 to 6 weeks. Because if we go beyond 6 weeks, we have to report to the government the value of goods and services that we're providing, and we'd rather not do that. So all it says is, we're providing you this stuff for free. We're gonna give you all the mods, all the disposables. You're providing the labor to fill the trays, and the nurses to put them on the patients. So, and we write in the number of mods. Again, just we wanna make sure we get them back in reasonable condition, so it's a very simple agreement. We will provide an appropriate number of devices. You tell us how many patients, we'll pretty much tell you how many we'll provide. But we've had cases where somebody says, could we have a few more? And we'll say, yeah, we'll send them. We want you to have the right amount of mods for the right amount of patients. We work with patient selection. We also have we have a lot of materials for you. We have a sample patient contract. Some hospitals want to read it to the patient, have them sign. I will only take this medication myself. I will take it only when I need it. I will not give it to anyone else. We have resources like that we can provide to you. We come in and do multi-shift training directly with you. So we walk you through the process and make sure you are qualified and signed off by the nurse educator on the floor that you are comfortable setting up a patient on the mod. Make sense? And then we have some evaluation forms, but oftentimes hospitals want to create their own, and it's a form that really is for the staff and for the patient. How does the patient feel about it? What does the staff feel about it? We just completed a trial, as I mentioned, at Tampa General. We put 50 patients on the trial. 49 out of 50 patients on their survey reported their pain was well managed on the mod. This VP of Patient Services said, that's all I need to see. I've not seen that from anything else before. Again, but it depends on the facility. And we come back at the end to debrief with you and get feedback and go from there. Cost, it's about $4,400 for one mod, but we have volume discounts. If you add up the mod and the software and the disposables, it's very comparable initial purchase to a PCA pump. When you consider the IV tubing, the bag, filling the bag, etc. Very comparable. So the more you buy, the cheaper it is. But it's in the name. Most people with the volumes they buy, it comes in about $3,700. We have a connectivity fee when we integrate with the network. We charge $35,000, which most people do charge a connectivity fee. IT is pretty familiar with that. We tried to keep it modest because it's not all that difficult. We're sending such small amounts of data over the network. What are we sending? The time, the date, the pain score, and the dose, because it knows what the dose is and what the drug is. I close with this from one of the nurses I worked with. She said this is relevant because we find when we put a mod in, we get all the staff facing in the right direction. Everybody focuses on patient care and patient pain management. And it's easier to do that when everybody speaks the same language. And you know, as you go into hospitals, you see very different ways of managing pain. And this tends to foster a dialogue and practice that then ends up marching in the same direction, which is a good thing. Thank you very much.